Awesome. We'll get started. My name is Taryn Hall. I am the program manager for the FDA task force here at Doctors for America. We are excited today to host a panel entitled Paths to Protection, Possible Ways the FDA can safeguard access to reproductive care. With that said, we're so excited to have a panel of phenomenal physicians and medical professionals who can speak to the current context around abortion care, reproductive care in the country, and we're excited for the discussion and look forward to their insights. With that said, I would love to turn it over to our moderator today, Dr. Atsuko Koyama, who is a physician and abortion care provider based in Arizona. With that said, I'm going to go off screen and turn it over to Dr. Koyama. Thank you.
Hi, everyone, and welcome to our webinar today. It's called Paths to Protection, FDA's Possible Role in Safeguarding Access to Reproductive Care. As Taryn said, my name is Dr. Atsuko Koyama, and I'm an abortion provider here in Arizona, as well as a pediatric emergency medicine physician, and I am a proud member of Doctors for America. So before we get started, I wanted to take a quick minute to invite each and every one of you to officially join Doctors for America. Being a DFA member today means taking the important and simple step of selecting a membership level and paying your annual membership dues to support DFA's organizational sustainability. A DFA team member will put the link to join in the chat. Also, we will be live streaming to Facebook Live and making a recording and all materials available afterwards. A few quick ground rules for this educational session. There's no such thing as a stupid question. And speaking of questions, please remember to use the Q&A feature. We'll also do our best to address all your questions during the second half of our session. And also look out for comments in the chat. DFA staff will be sharing helpful links during the session. So now on to today's panelists. We're so excited to welcome today Dr. Amit Sirpotwari, who is an assistant professor of medicine at Harvard Medical School. His research draws upon his interdisciplinary training as an epidemiologist and lawyer and focuses on the effects of laws and regulations on therapeutic development, approval, use, and related public health outcomes. And also, Dr. Deborah Bartz is an obstetrician gynecologist, fellowship trained in complex family planning at Brigham and Women's Hospital in Boston. She serves as a faculty expert in complex dilation and extraction techniques, medication abortion, and contraception care in the medically complicated patient. So without further ado, I'd like to welcome first Dr. Sirpotwari.
Sure, it is a pleasure to join you. Can everyone see my slides? Terrific. All right. So I think at this day and age, probably can be a more important topic. Thankful for Doctors for America for the opportunity to come and talk about ways to safeguard access to reproductive care, with a particular focus on the FDA's role in this issue. So just by way of background in terms of disclosure, I'd like to note that I did serve as an expert witness for the ACLU in a case I will talk about, challenging the restrictions on mifepristone use during the public health emergency. I'm also a principal investigator on a study of REMS, which we'll also talk about, which is being jointly run with the FDA. So I'd like to start by just giving a general background of the Dobbs case and its holding. And I think just to set the grounds of this debate. So the Mississippi had passed a law, the Mississippi Gestational Age Act, which restricted abortions in the state to up to 15 weeks gestation. Now that was definitely would have been unconstitutional under previous precedent. They had exceptions for medical emergency and severe fetal abnormality, but as we'll talk about, those are vague terms. And really the context for this in which the Supreme Court was evaluating this case, two important case precedents were there. Roe versus Wade, which I'm sure everybody is familiar with, which established a fundamental right to privacy that encompasses abortion. So the court had previously identified that the Constitution had a fundamental right to privacy, and said in this case that that right encompasses the right to an abortion. They had a trimester framework in which only minimal safeguards were allowed in the first trimester. Now, 20 years later, Planned Parenthood versus Casey was another decision that the court issued, in which they upheld the right to an abortion, but instituted a lower undue burden standard. So with this undue burden standard, they struck spousal notification requirement under a Pennsylvania law, but not parental consent, informed consent, and 24-hour waiting period. The decision in Dobbs, however, explicitly overruled Roe and Casey and found that those decisions were erroneous, that the Constitution had no right to an abortion. That meant that states are able to impose extreme restrictions and outright bans on abortion, be it medication abortion or surgical abortion. So what is the landscape now post-Dobbs? As you can see, there's been a flurry of activity with 84 bills introduced, some of these trigger laws that would have automatically taken effect were the Supreme Court to overrule Roe. And 7 of these laws have been enacted, which ban all or most abortions. And as you can see, those are largely concentrated in the South. There's a range of severe restrictions, complete bans, basically with no exceptions, to less severe restrictions, which we'll talk about in just a second. But the landscape is shifting rapidly under our feet. What are the consequences? Well, already just ripped from the headlines, you can see numerous consequences. A 10-year-old rape victim forced to travel from Ohio to Indiana for an abortion. People with pregnancy complications in which there are life-threatening issues, being unable to get timely care. In Nebraska, most recently pulled from just yesterday, a teen and mother facing charges in an abortion-related case that involved obtaining their messages from Facebook. Just general confusion and hesitation about providing potentially life-saving care for fear of what state action might be possible. So I want to focus, after setting that landscape, on medication abortion specifically. And so increasingly, it has been used over surgical abortion. And so from the Guttmacher Institute, you can see that from 2000 to 2020 in the United States, that now you're talking about more than half of all abortions being handled with medication as opposed to surgery. In terms of the use of medication abortion in the post-Dobbs era, it is harder to police and potentially in that respect has promise as an avenue to provide reproductive care. The common regimen of mifepristone plus misoprostol is extremely effective. So up to 10 weeks gestation, over 95% effective. The drug's history, specifically mifepristone's history, it was first synthesized in 1980, approved for use in France in 1988, and in 2000, approved by the FDA. The original indication was for the medical termination of intrauterine pregnancy through 49 days pregnancy, so 7 weeks. In 2016, it was a revised indication, which noted that it is a drug to be used in a regimen with misoprostol for the medication termination of intrauterine pregnancy through 70 days gestation, so up to 10 weeks. So the FDA specifically evaluated the safety of potentially extending the indication use from 7 weeks to 10 weeks and agreed that that was safe and effective. And so in 2019, you had the first generic entry of mifepristone, and they operated under a shared safety program, which I'll talk about in just a second. So what are the safety issues with mifepristone? Well, the purported safety issues are concerns over bleeding and infection. So originally, the drug was approved with a safety program that was mandatory, and that's surprising because before 2007, actually, there was only certain drugs approved through certain pathways that could have mandatory safety programs, and mifepristone was one. What this safety program did was restrict dispensing to physicians who attested to the ability to assess the duration of pregnancy, to diagnose ectopic pregnancies, and provide surgical intervention or access to medical facilities able to provide blood transfusions in case of incomplete abortion or severe bleeding. It required patients to receive a medication guide on safe use conditions and required patients and physicians to sign agreement forms. In 2007, the FDA was granted the authority by Congress to have safety programs called risk evaluation mitigation programs on any drugs, regardless of their approval pathway, if necessary, to ensure that the benefits of use outweigh the risks. Mifepristone was deemed, in effect, to have a REMS because it had a safety program that was mandatory beforehand. But Danco, the manufacturer of the brand name drug mifepristone, Mifeprex, submitted a new proposed REMS that was approved in 2011. It kept the same use conditions, but also added the requirement for 3 physician visits. So now, in terms of patient access, this has made it even more difficult to access mifepristone for medication abortion. But let's take a look at the deeper dive into the mifepristone risks. So mifepristone is also not only extremely effective, but extremely safe. So a 2016 FDA medical review found that major adverse events, including death, hospitalization, serious infection, bleeding requiring transfusion, and ectopic pregnancy with the proposed regimens are reported rarely in the literature on over 30,000 patients. The rates, when noted, are extremely rare, generally far below 0.1% for any individual adverse event. As a result of this review, the FDA changed the REMS. It said that a medication guide was not needed. It expanded who could dispense to non-physicians, but they still needed to meet those conditions of being able to diagnose, et cetera, and reduced the number of required office visits from 3 to 1. And this is where we start having challenges to the program. And so ACOG, the American College of Obstetrics and Gynecology, during the public health emergency, during the pandemic, challenged the fact that the FDA kept restrictions in place for the use of mifepristone, but actually relaxed requirements for other programs. So they suspended in-person visit requirements before prescribing Schedule II narcotics, in-person visit requirements for clinical trials of investigational drugs, and for other drugs with REMS, the requirement for laboratory testing and imaging. But for mifepristone, the FDA kept the in-person dispensing requirement. And so ACOG and others challenged the FDA on this. and they were successful. Essentially, what happened is FDA agreed to review the data on the safety of mifepristone use during the public health emergency and said that they would continue the suspension of the in-person dispensing requirement during the pandemic. That was a narrow challenge, though, focused on a temporary relaxation of the REMS. There was a broader challenge that was brought years earlier, in which a doctor from Hawaii who was a board-certified family medicine with a focus in obstetrics, and the chief medical officer for the Hawaii Health Systems Corporation, in which the population was 65,000, wanted to prescribe mifepristone as part of reproductive care, but had a fear of inducing conflict among colleagues, so he does not provide abortion care, and wanted to challenge the existence of this REMS. And the challenge brought forth several legal questions: whether the mifepristone REMS violates substantive due process rights, so the fundamental right to an abortion that still existed at that time, whether mifepristone REMS violated equal protection rights, and whether imposing the mifepristone REMS the way it was done was a violation of the Administrative Procedures Act. So basically saying that given the evidence that was there and the standards that are necessary to impose a REMS, that the decision to have this in place was arbitrary, capricious, and abuse of discretion. Now, again here, through a lengthy litigation process, the parties agreed to stay the litigation while FDA said it would conduct another review of the mifepristone REMS program. In December 2021, the parties, FDA agreed to no longer restrict dispensing to clinics, medical offices, and hospitals, said that they would impose a certification requirement for dispensing pharmacies and prescribing clinicians, and kept patient counseling. So basically what they said is, we're going to keep the REMS, but get rid of the in-person dispensing requirement as part of the program. So that's where we stood until Dobbs took place. Now, I think there's very good evidence to say that FDA should have eliminated the REMS altogether. And the question is, would that, in this current landscape, how much would that help? So if you're talking about some of the early laws that took place pre-Dobbs, they had imposed physician-only prescribing requirements. Just prior to Dobbs, some states like Texas required physicians to ensure that a patient is no more than 7 weeks pregnant. So you can see how that directly conflicts with what the indication was, up to 10 weeks pregnancy. And so now the question is, does some of these laws that were enacted pre-Dobbs, but also some of these laws post-Dobbs that restrict access to medication abortion, should they be preempted under federal law? And what that generally means from a legal standpoint is, where federal law and state law conflict, federal law should trump. That's the general concept. But in the post-Dobbs landscape, you're seeing different types of restrictions. Some restrictions just on mifepristone access, which may be grounded in safety, others which may be grounded in morality, outright bans on medication abortion, and outright bans on all abortions. And so one question that naturally arises is, well, why wouldn't states just do outright bans on all abortions? Well, the political climate in certain states and the fear of possible economic repercussions of banning all abortions may make it only politically feasible to impose partial restrictions on abortion. So you still do have the possibility of this range of restrictions on mifepristone access. So in terms of the preemption challenge, preemption can be express preemption. Congress passes a law and says that if there is any state law that conflicts, we are saying that explicitly that we intend to trump that state law. But then there's implied preemption, which is can have different shapes as well. impossibility preemption, a precedent that includes sort of stop selling solutions, obstacle preemption, in which a state law thwarts the purpose of federal law, and the general argument for possible preemption is state required measures beyond those in the REMS upsets the complex balancing between the safety and burdens on the healthcare system that Congress specifically delegated to the FDA. This is likely more plausible when state laws are restricted to medication abortion and grounded in safety concerns. The possibility of preemption in the case of an outright ban on abortion altogether is going to be more difficult. I realize I'm a little bit over, just 2 more slides to go. And I think that the probability of seeing preemption from a legal theory standpoint, there is a strong argument that these laws, many of these state laws, should be preempted. But the reality of political ideology on the court and the polarization of this particular issue means that it is probably unlikely that we can rely on preemption as a way to increase access to mifepristone. What we can, though, do is petition the FDA to outright remove the REMS. And many groups have called for the elimination of the REMS altogether. So what else is possible here in terms of physicians? What steps can physicians take to promote reproductive care? Obviously, effective organization at the grassroots level is key, and I applaud Doctors for America for their efforts in doing that, not only in this issue, but other issues as well. The creation of care networks, which Dr. Bartz will talk about, the ability to facilitate out-of-state care, the ability to expand potential prescribers to not just reproductive experts, but in partnership with reproductive experts. We should apply all challenges possible. So even though the preemption challenges may not succeed, they should be pursued. The FDA should be petitioned to remove the REMS on mifepristone altogether. And particularly at the state level, I think there is a huge opportunity here to highlight, providers highlight the adverse effects of potential restrictions on the health of women, and also the exodus of providers and what that may mean for the economy of the state. Lastly, you can obviously, through organizations, support reproductive rights proponents for office, and frankly, run for office as well. And I'm hopeful that we will see more physicians running for office in this climate, because I think that is necessary. So thank you.
Take it away, Dr. Bartz.
Sorry, just lost my unmute button. Couldn't take it away as much as I wanted to. It is such a pleasure to be here with all of you, and I really appreciate both the mission of Doctors for America as well as the opportunity to speak with you. So thank you. As mentioned, I have been an abortion provider for the last 15 plus years, and to complement Dr. Sarpatwari, I am going to maybe move into a little bit more personal space, both for myself as a reproductive capable individual, as well as a physician, to give some experience with regards to the patient and the physician level experience of abortion. And I'm going to actually ask that you kind of think about doing that too with me. And so to start, I'm actually going to ask you to think about what you think about when we talk about abortion prior to Roe v. Wade. So prior to 1973, when you think about abortion and abortion providers, what comes into your mind? Most likely for most of us, we actually have a pretty negative connotation. Most of us think of like back alley abortions, botched abortions. There can be some really negative terms that are associated with those. But what sociologist Carol Jaffe brings up in her book is actually that pre-Roe, actually had the same doctors providing abortion services as post-Roe, that there actually was not something magical that happened in 1973 that all of a sudden trained up a physician workforce to start being able to provide safe abortion care. The WHO defines unsafe abortion as abortions that are done either by individuals without the skills to provide that service or under unsafe conditions. And certainly because of the vulnerability of abortion care pre-Roe, it did allow some rather nefarious characters to indeed start to capitalize on the vulnerability of desperate women seeking out abortion services and providing truly unsafe abortions because they didn't have the skill set to be able to do that. However, there really was a fair amount of physicians that were skilled. They just had to perform these procedures in the shadows, oftentimes under unsafe techniques because they could not do them in clinics and with the modernization of the medicalization of abortion that could happen in 1973 when it became legal and moved out of the shadows. So with regards to that physician workforce, what you see here is a graph over time of who the providers are of abortion services, with the bottom or the lighter blue bars representing those within hospitals. And as you move up, it moves into larger independent clinics with the green bars up at the top. This is just number of providers. And if we actually think about number of procedures performed by these various groups, indeed, the large non-hospital independent abortion clinics, so this could either be a Planned Parenthood affiliate or it could be a independent National Abortion Federation type of clinic. Those two together make up over they perform over 90% of abortion procedures, with less than 10%, well less than 10% being done in our hospitals. And you can see what happened over time was that Roe v. Wade was passed in 1973, and these providers who've been providing previously were able to come out of the shadows, start providing medicalized abortion-specific care, many of which did that in the hospitals to start, but were quickly moved out of hospitals and had to start providing care in independent clinics. And because there was no training specific for medical professionals in abortion services, those doctors had to keep staying on and providing care within their independent clinics, somewhat removed from the medical community otherwise. So abortion care has very much been regulated into the outskirts or the periphery of medicine. And when I went through medical school, I graduated medical school in 1998. And very deliberately, when I was there in medical school, I sought out one of these independent clinics in Madison, Wisconsin, and met someone in his mid-60s, Dennis Christensen, who was providing all abortion services in Madison at that time. And I came to recognize as part of my process that because all these providers had been trained and had the mission of providing abortion services from pre-Roe, the workforce providing abortion services in the 1990s was actually of the age group of about the mid 60s. They were very much a gray looking to retire workforce. And that motivated me to, as it's probably motivated many other abortion providers, to actually pick up the torch and give those older providers a break. And so indeed, I joined the fellowship in family planning. I was not the only one that was having real concerns. Many people are having concerns about the physician workforce in the 1990s. And so several things opened up. There was a Ryan residency training program. So if you were in residency ahead of the 2000s, you likely did not have a Ryan residency training program as part of your OBGYN clerkship in med school and in residency. And you can see on the map all the states that now do have a residency Ryan training program, with the idea of training up primarily OBGYN doctors in providing abortion services, but also family medicine doctors. And because many of these Ryan programs, including my own at Brigham and Women's Hospital and Harvard Medical School, actually have specific medical school curricula, the idea is we're actually trying to affect the whole physician workforce to move the whole dial on improved abortion sympathy, even if they're not going to be providing abortion care, with the idea that we could stop marginalizing abortion services to the very few that provide those services, and having the rest of the physician workforce not have a good understanding of what abortion care actually is and involves at the physician and the patient level. And because there's so many people that have graduated from these Ryan residency training programs and fellowship programs like myself, we now have an academic society, the Society of Family Planning. We're fully credentialed through ACOG and ABOG, and it's a fabulous community to be a part of. I'm really proud of it. This is the incidence of abortion over the course of the last 50 years. Probably on the left-hand side of the graph, the slope is largely because of underreporting of factual numbers, but the slope on the right-hand side of the graph is indeed truly because we've been able to bring the rate of abortion down significantly over particularly the last 30 years. The most recent numbers just came out within the last few weeks. And while we've been experiencing a decline for 30 years, we all of a sudden have this little bump back up. In the United States, as of 2017, there were 860,000 abortions that year, so just under 1 million. And in 2020, that actually bumped up to 930,000. And the reason for that bump is projected to be two things. It's probably because the Trump administration slashed a lot of the Title X funding, and a lot of primary prevention contraception services were shut down. And it also has to do with several states, most notably Illinois and Maine, increasing accessibility to abortion through allowing Medicaid state funds to pay for abortion services for Medicaid recipients. Who has abortions? So the most common people that have abortions are in their 20s. They're married or cohabitating. They're of all religions, and most of them report that they are religious. They are using contraception, but just not using it well in the month prior to getting pregnant. And the majority already have more than one or more children at home. And this is just to say that, I mean, I remember very explicitly in Madison, Wisconsin, going into that first abortion clinic and looking around and saying, where are all the teens? Where are all the irresponsible people? I don't understand. And it really is, I'm trying to dispel the myth that we think we know who the abortion patient is, and the abortion patient is actually, looks very much like each one of us, no matter what we look like. All identities are included. Unfortunately, what's happening is there's an increasing concentration of abortion need within those with less resources, and so we're seeing that people who live within poverty are needing more abortion services than not, probably having to do with poor access to healthcare in general, including primary prevention with contraception. There have been a lot of downsides to abortion being regulated to these independent abortion clinics. It's made us very vulnerable to legislation, just like Dobbs. It's made our patients very vulnerable to experiencing harassment, and our providers very exposed to harassment in these community-specific clinics. However, one really cool thing about abortion care is that when it's regulated into these ambulatory surgery centers like independent abortion clinics there might be a day where I'm at the local Planned Parenthood affiliate and doing close to 30 procedures in a day. And my skill set is getting so much better just by doing these high volume of the same procedure day in and day out. So this is something that the rest of medicine is really picking up on. There's a lot of surgical subspecialties that are recognizing that having a niche and doing the same procedure over and over and over really increases the safety of a particular procedure as the provider gets more and more skilled under that scenario. Abortion was really the first, I would argue, to create that model in surgical experience. So what I tell my patients is what's presented here on the slide is that abortion, just by getting pregnant, a person puts themselves at higher risk at baseline. You've just made yourself less risky, more risky for some sort of health outcome to happen. But abortion it's been figured 14 times safer than continuing the pregnancy to term. So all these restrictions on abortion that claim that they're surrounding the interest of patient safety really are quite, disingenuous and frank disinformation, because you would have to increase the risk profile of an abortion 14 times to even equate to just the experience of pregnancy and delivery, not to mention the experience of forced pregnancy, the emotional experience of forced pregnancy and undesired child rearing down the road. We are moving the gestational age at which abortions happen earlier and earlier within the United States. As you can see from this graph of 2001 to 2011, in the first trimester, more and more cases are indeed eligible for medication abortion, and earlier, less significant medication abortion. What we're not able to touch has been second trimester. Those who need second trimester care are always going to need second trimester care, most likely. Primarily what that is made up of is patients with desired pregnancies, where a fetal anomaly is diagnosed by the the anatomical ultrasound scan, usually around 18 weeks, as well as these have-nots in medicine, the patients who have a hard time accessing healthcare at baseline, and therefore frequently are relegated into abortion services into the second trimester. Dr. Surpatwari demonstrated this graph as part of his talk, and I just wanted to emphasize the patient experience with medication abortion, in that it really is the equivalent of inducing a miscarriage. It is profoundly different than a surgical procedure. I personally have gone back and forth on what I would want if I needed an abortion procedure. Originally, I was thinking, oh, I want the very medicinalized, done immediately surgical procedure. Don't have to feel it under, having it under sedation of some kind. The fact of the matter is I've switched my own tune, and I think there are many patients clearly who highly desire the very different patient experience of taking the pills, having this personal experience at home on their own time, in their own setting. They can involve who they want, or they can involve nobody. If they don't have to find a ride to drive them, particularly if that drive means crossing state lines, that sort of thing. So I do want to emphasize that this experience is the same experience as having a miscarriage. Currently, miscarriage happens in about 1 in 5 pregnancies. That means that patients are having the exact same experience as the mifepristone misoprostol experience at home on their own off REMS. So the fact that REMS is only covering about 1/3 of the patients who are experiencing these symptoms, in my mind, kind of does do away with the idea that the REMS is a necessary part of care, since so many patients are able to do this at home naturally, as part of the miscarriage experience. So the importance of access, legal restriction is only part of access. Partner and parental consent, poor access to facilities and providers, costs, social stigma, fear of abuse, insufficient services, all that has resulted in this map on the left-hand side of the slide with regards to the fact that the United States has always had deserts, abortion access deserts, designated here geographically by the red portion. And by this map that Dr. Surpatwari also included, you can see, you can think about how layering these red and orange states on top of the 2017 map is just really going to lead to true abortion lack of access for millions of patients. It's projected that it would probably be double, more patients would lose access than would retain access if indeed all states have abortion fall as is projected, including states like Arizona and Utah, Wisconsin, Indiana, some states that are at real risk of losing even what's currently listed on this slide. So what can you do? I guess I would ask that you really think about talking about abortion with much greater regularity. So this, you want to talk to your patients, you want to talk to your professional colleagues, you want to talk to your personal community and destigmatize the word abortion and emphasize the idea that abortion is safe and an important part of autonomous reproductive care. And we've really nicely been seeing people coming out in our journals, these editors coming out with very bold language, talking about abortion services and the importance of abortion and how patients will be harmed and people will be harmed under these extreme abortion restrictions. I'd ask that you as medical professionals identify the lowest health and legal risk path for patient care, which may include self-managed abortion, and really familiarize yourself with how to create good referral processes for patients. Even in studies of OBGYNs, about a half of OBGYNs do not know where to send their patients for abortion care. Number one, it'd be really nice if we could incorporate abortion care into all those OBGYN practices. But that aside, if you're not an OBGYN and or you're not in a position to incorporate abortion care into your practice, these referral pathways are now all of a sudden incredibly circuitous. And they are usually left to the patient to look online and find out herself how to get to abortion clinics. And the online data is, ripe with misinformation and deliberate disinformation that we need to help our patients avoid. If you can use these web pages that I have listed up here as potential resources in the future so that you can help your patients move forward. Really think about to what extent you might be able to provide abortion services yourself in the future. You do not need to be an OBGYN. Many family medicine, many internal medicine, emergency medicine, pediatricians provide abortion services. At our local Planned Parenthood affiliate, we actually have had a pathologist on faculty. We've had a radiologist on faculty. You all are smart enough to be able to work through the training that's needed to go through particularly counseling a patient through the medication abortion experience. So I'd highly recommend that you, if you're in an abortion friendly state, think about taking the burden off those of us that are providing more complex cases, knowing that a lot of patients are going to make their way into the second trimester and need our surgical cases. Think about how you can release the burden to some extent for some of these abortion specific clinics and integrate abortion as it is essential healthcare. It's just like any other healthcare procedure. And then lastly, I'd ask that we all think about not contributing to patient criminalization. So there have been 21 people since 2000 who have been criminalized for abortions, and that number is rapidly upticking, many of whom were reported by members of the healthcare community. And we really need to think about how that is a violation of HIPAA, how that's a violation of our Hippocratic oath to do no harm. And that oftentimes in the way that we talk to patients, we really want to make sure that we get enough information to be able to take care of them and not move into the space of needling them for what they may have taken, that whether or not their miscarriage that they're presenting for in front of you is an induced miscarriage or a natural miscarriage, that sort of thing. So we really want to keep that at the forefront of our mind. And with that, I thank you for your attention. Let me stop sharing.
Thank you so much to both of you for this incredible information and the passion with which you advocate for patients' rights around this issue. I just wanted to take a quick moment to remind everyone who's on this call, please use the Q&A function to ask any questions of our panelists. I just wanted to give a brief overview of what both our panelists went over. Dr. Sripotwari talked briefly about the Dobbs decision and the consequences and some legal ramifications and possible legal routes to which we can address the aftermath of the fall of Roe. He also talked briefly about the medication abortion, how half of all abortions are now, a little over half, 54% of abortions are via medication abortion. And how it's over 95% effective up to 10 weeks gestation, and really gave us a great overview of what the REMS, the risk evaluation and mitigation strategies, the REMS criteria, and what that means for medication abortion, including the history of REMS litigation, and really trying to talk about how important, how wonderful it would be if we can get rid of the REMS for mifepristone. Dr. Bartz provided us a great overview of the abortion provider landscape from the 1970s to today. and described abortion rates and types of abortions, when people get them in pregnancy, weeks in pregnancy, who gets them, the population of people who seek abortions, mainly now in particular, those living at and below the poverty line, and people of color. Discuss the safety of abortion, especially in relation to continuing a pregnancy, and how it's 14 times safer than continuing the pregnancy to term. She also discussed the
Dr. Kuyama, I
dogs.
think you're muted.
Yeah. Oh goodness. I am?
No, I hear her fine.
I can hear her.
Oh. Okay. Yeah, I don't think I'm muted. And she also discussed how the Dobbs decision affects the abortion deserts, and how people who have already had systemic and institutional barriers to access, how this will affect them greater. Being an abortion provider here in Arizona, we have felt this personally. Here in Arizona, we have very few clinics who are providing at this time, given the uncertainty of our pre-statehood law from 1846 that will be heard. There's a current injunction, but there will be another court hearing on this on the 16th. And so several of our abortion clinics are no longer providing until that hearing takes place in a week. So, this is real, and this is something as the action steps that both our physician panelists discussed today. I think it's super important, and the action steps of being registered to vote. If you're not registered, vote, run for office, really destigmatizing abortion, saying the words as physician of all different specialties, and how important it is to support those who are continuing to provide, and some of those things too. As part of the abortion provider community, people have talked about how pathologists, how we need to go to our hospitals and figure out what pathologists have to put in their documentation, their reports, to ensure that we're not criminalizing patients. Do you write that there's foreign material in the sample? How do we talk about it? If someone has a miscarriage and or discusses self-managed abortion in the ED, what is our responsibility as an emergency medicine provider to send to pathology or not? Or there's so many different layers to this, and so many different people who can really address how to support our pregnant patients, our post-abortion, our post-miscarriage patients, so that they can be safe and our providers can be safe from criminalization. And also, both of them talked about getting rid of REMS, dismantling misinformation around abortion, improving referral pathways. And so, again, I just wanted to thank you both for your amazing presentation. I want to get to some of these Q&A questions. One person asked, is there any training for non-OB-GYNs on the use of mifepristone? Dr. Bartz?
I accidentally hit that I would answer this live, but I did answer the first question with the URL for this group called Abortion Pill. .org. There is this, I just can't, let me see. Let me put it in can I put in the chat? The URL.
Yes, and we will definitely also be able to send out information that's covered here to participants of the call after the call.
I'm putting another one in the chat that is actually a online module for training in abortion service, in medication abortion specifically. It says that it's for family medicine docs, but honestly, it could be for anybody. I think the one thing that you probably should think about doing as you consider whether or not you could incorporate this as part of your care is think about developing a relationship with someone who could manage the 5% of cases that are not successful, some of those can be managed with a second dose of pills, but at some point there are going to be some patients who would like to have the surgical DNC procedure, the aspiration procedure. And so it would be good to develop a relationship with somebody if you yourself are not going to do those surgical cases, that would be willing to see your cases as needed.
Also, as an emergency medicine provider myself, there is one emergency room in the country at Stanford. Dr. Monica Saxena worked relentlessly over 2 years to make mifepristone available in the emergency room. Of course, this is all state dependent. Here in Arizona, we have a 24-hour waiting period, so we would never be able to provide Miffy in our ED. But just even, making sure that our miscarriage management is up to par and at standard of care. We are not providing Miffy in our to the best of my knowledge, we're not providing Miffy to all those who would be eligible for Miffy after miscarriage management. And so, just making all abortion care, miscarriage management free of bias, free of all this misinformation, I think also pushes that needle forward to make abortion more accessible to everybody.
Yeah,
and I think that I just quickly add that I think that Arizona state law would be something that is ripe for a preemption challenge, because FDA has specifically evaluated what is needed to ensure safe and appropriate use, and a 24-hour waiting period was not one of the things that they said. So, those are the areas in which I think there are some, I wouldn't say low-hanging fruit, but aspects in which you can take action or help start the wheels in motion to take action against some state laws. Sorry, thanks.
No, and then what I was going to say perfectly is just the clinical adjunct to that, which is that when studies have been done to look at people's experience through the abortion experience, they've timed out how long it takes a person to decide between finding out that they have an undesired pregnancy and deciding what to do with it. So think about yourself. What's an answer of how long do you think it takes? What's the median number of days it takes for someone to think through that process? When I ask that question to our med students and even our residents, they'll give me answers like 3 days, 7 days, 30 days. The median number of days is 0 days. Typically, when a patient is peeing on the stick, she's deciding who's going to drive her to Planned Parenthood, essentially, before she even gets the results. So that's just that's a dispelling of myth that these waiting periods are needed, and can make you feel good about providing abortion services even in the emergency room when a new diagnosis is made.
100%. But also, just to be clear, people need to continue to practice within their legal boundaries of their state. So I agree that waiting periods are not there for the safety of our patients, but here in Arizona, unfortunately, we do have that. Also, another question, my organization is putting together a quote community care toolkit, unquote, to help activists support providers, patients, and help protect their communities against faux clinics. Any messaging or materials you all would suggest for that? I think this is a great question, so important. If, when, how, .org is an amazing organization of legal experts, lawyers who are really fighting the good fight to ensure that people who do seek self-managed abortions are not criminalized. They also have a wiki page for minors. So if you do have someone who is 17 or under who is seeking abortion care, you can drop down to whatever state that patient is in to see if there is a requirement for any kind of parental notification or for judicial bypass resources and whatnot. Here in Arizona, like I said, we're still providing abortions. And so it's a great place for teenagers, for minors to find resources that they need to figure out how to seek abortion, because we do, unfortunately, without parental consent, they cannot seek without a judicial bypass. like I said, in California at Stanford, it's really wonderful because you don't need any of that. Very supportive abortion policies. And so even if an adolescent goes to the emergency room, they can seek abortion care. And then also, so if, when, how is a great place to look. And then there's also a great website that I will have to, you can just Google, but you can search for fake abortion clinics, women's health clinics, to figure out where those crisis pregnancy centers are located and how many are in your state. So that's another great website for people to check out before they seek care in their city, to ensure that they're receiving care from a comprehensive clinic that does support abortion care if that's what they choose. And then also taking a look, and I would highlight Catholic hospitals or other hospitals. Here in Arizona, we do have a large number of Catholic hospitals. So I think it's important to encourage people who are pregnant to ensure that they know which hospitals are secular, which are religiously affiliated, because in an emergency, if you are pregnant and bleeding and you call an ambulance, they will take you to the closest hospital. In some of these big cities, I did also practice in Boston, where there's a ton of different hospitals all in one small, tiny area. And so sometimes if it is not a dire emergency, you could request a hospital for them to take you to. So knowing which hospitals provide secular medicine might be of use to your patients. Do other panelists have any comments or resources to provide? Oh, thank you, Dr. Burtz.
I might have put the wrong one in the actual answer. I think I had something else that was pasted, but I just put in the prochoice.org. They have investigated clinics by a secret shopper. And so they're able to speak quite well on what's a real clinic versus not.
And I posted one that hopefully will get out to everyone about, the reach of HIPAA, what it does and doesn't do. And in light of a lack of stronger privacy protections, sort of how providers, recommendations on how providers should handle information that may ultimately be used to go after individuals under state laws.
Also, I can send to Taryn the handout that If, When, How has for patients to know their own rights. And I would, consider really pushing for everyone to know what the emergency room is doing, know what their clinics are doing in terms of when someone has a positive pregnancy test, or if someone presents to clinic asking for a pregnancy test. Like, is there a way that we can advocate for our patients and hand them something or a link? This gets very difficult, and it is something that, when you're working with hospital administration and risk and legal, if it's to have like your hospital logo on it, there's all kinds of roadblocks to this, and it is hard work. But in places that might be open to this kind of patient education, I think that it's a great thing to work towards, to ensure that patients know their rights, especially, if in states where there may be weeks of pregnancy restrictions. In terms of, in Georgia. So I was here, before I was practicing here in Phoenix, I was in Atlanta, and they just passed their 6-week abortion ban. So, making sure that people who are of reproductive capability, that they understand where they can get pregnancy tests, where they can get seen right away, so that they have options. And so these are all ways that, regardless of what your specialty is, we can really try and protect our patients to ensure that they have options.
Fantastic. Well, thank you, Dr. Koyama, Dr. Bartz, and Dr. Serpatwari. This has been a really robust and informative session. I will send around all the resources and links to our YouTube, which is where this presentation will live. Thank you also to the physicians, medical professionals, and just general folks from across the country who've joined us today, who are curious about this work and want to continue to do the challenging but necessary work to make sure that folks know what's possible with abortion access. So with that said, thank you so much and have a wonderful Thursday. Oh,
thank you.
And last thing, I'm going to drop in the chat.
The survey.
A survey, yes. There's a survey for feedback. And then Doctors for America is also hosting our National Leadership Conference this September in Chicago. So there's a link to RSVP. There will be plenty of amazing speakers and physicians presenting there as well. So those two links are in the chat. I will also send them around as we send around resources for this webinar. Now, with that said, I hope you all have a wonderful Thursday.
Thank you.
Bye.